Hi, good evening. Hi, welcome everyone. And welcome to Andrew, who's a consultant in podiatric medicine and surgery. And he's very kindly come along to give us a talk to explain some of the intricacies of what he does, including surgery and cryosurgery on Morton's neuromas. Thanks very much.
Thank you very much, Anthony. So what I would like to present is a little bit of background about me, about how I came to be here, particularly about Morton's neuroma and cryosurgery as an option for treatment, a little about other things around differential diagnosis as well. As was said, my background is I sort of started life as a podiatrist, qualified in 1988 from Northampton and Leicester Medical School, because it was part of the same organisation at the time. And I was very interested in surgery, but the only way I could sort of develop the surgical side of things was to become head of department, which I managed to get fairly early in my career. And then I had an opportunity to go and do some research at the University of Liverpool under Professor Simon Frostick, looking at a number of aspects of foot and ankle surgery, particularly at the time, and also plan to heal pain. But it was during this time that I got quite interested in cryosurgery, because I was introduced by a colleague of mine that in North America they were really specialising in this type of freezing technique for plantar fasciitis, but also for neuromas. This was using a nitrous oxide, which at the time wasn't really cold enough, and I wasn't getting the results, so I sort of ditched that and moved away, and then concentrated on surgery. But because of that, I still had that interest, and it wasn't until a few years later that during a meeting for orthopedics that I actually stumbled across into a urology meeting and met guys from Galil Medical, which was the original people that produced the cryosurgical units, which is used in other aspects of medicine, which we'll talk about a little bit about later. So that's my sort of background, really. I've put this little slide up just to explain a little bit about foot and ankle, just a very general slide that I often give to patients when I'm giving talks to patient groups. And you can see a number of issues around foot and ankle, and really this is to illustrate it's so important to get the diagnosis. In any type of medicine that's obviously obvious, but sometimes, especially in foot and ankle, we tend to give generic titles to things like metatarsalgia, which just means pain in the metatarsals. So it's important when you're looking at it to think about differential diagnosis. And here at Enigma, we're able to consult patients. We have diagnostic ultrasound. We can do skin and soft tissue surgical procedures upstairs here. We do have obviously the cryoablation, which we're going to talk into a little bit more detail. We do have some platelet-rich plasma, so we can do a number of injections, as well as corticosteroid injections, which we do a lot of. And because we're linked to the gym, we can actually I do some gait analysis and sports injury work as well over there. And we can do medical legal work as well, which I do some here. I've just put these horrible pictures up to see the type of nail conditions that we often see, and they're pretty grotesque, but this is something that we can do here, and there's a lot of these type of cases that come through. But we also linked to other hospitals. I do work at Nuffield and Spire Hospital, so if we have patients that, for instance, we're not able to have x-rays here, which perhaps we may be able to have in the future, but as you can see, you can just about make out at the bottom. Sometimes if you have an ingrowing toenail that's not healing, you can see at the bottom there's actually a subungual exostosis that needs to be removed, so a bit of bone needs to come away. This can often be missed. You don't see these very often, but it can be there. So that's again important about the diagnosis. Again, when you're looking at foot and ankle, it's important to know your anatomy. I'm not going to go through this in any great detail, but it's imperative that we're able to do that, as well as some gait analysis and the biomechanical side of things. When we're looking at metatarsalgia, that pain in the forefoot, one of the most obvious things, especially with Morton's neuroma, is high heels. So sometimes, if you're in general practice, it's important just to give them a little bit of footwear advice, because that can often reduce the amount of force that's going under the forefoot, and also the impingement, which is very important in Morton's neuroma. And also runners, when you do see them a little bit more in sports patients, because of the fact they're running on their toes and they're putting more forefoot pressure through there. Again, it's a very busy slide, I'm not going through in great detail, but again, that's just to look at differential diagnosis. What's the other cause of pain in the forefoot? If you scan a patient for any condition, you may find a neuroma, but it's not causing any pain. Sometimes up to a third of cases that you scan in the forefoot, you'll see a neuroma, but it may not be causing the pain. So you've got to be careful that you treat the patient and not the scan. Sometimes you get swelling in the forefoot, it can be gout, you've all heard of that. Pain in the big toe, but it can affect any joint. It may be a systemic condition if it's bilateral. It may be something like rheumatoid arthritis or a seronegative, so you need to pull the bloods and all the other aspects for that. It may be a stress fracture. Sometimes I've had referrals to say, this patient's, I think it's a neuroma, they've got a lot of swelling. Well, you never get swelling with a neuroma. And often it can be something like a stress fracture that's been missed. Remember, if you see somebody with a stress fracture, within the first 2 weeks you don't see anything on x-ray. So it's important to leave it a little bit before you x-ray it, unless you've got access to other tests. It can be diabetes, we know, with the diabetic complications, and it may be causing neuropathy, so they can't feel their feet, they're getting nerve symptoms. So it's important to realise that, as well as some other things such as cancer, endocrinology, and other aspects. Sometimes you can get osteochondritis, in other words, the metatarsal head, post-trauma, just starts to lose some of its bony mineralisation and has to remodel. And that can often be quite a common cause of pain, especially in females around early 20s. So anyway, we've ruled that out. So what I'm trying to say here is that it's really patient selection that's important if you're going on to treatment. Metatarsalgia, you've ruled out other aspects, but could it be what we're really talking about is a Morton's neuroma? Now it's a Morton's neuroma. Morton was an orthopaedic surgeon that first sort of coined the phrase. It was actually first described by Durlacher, who was the chiropodist to Queen Victoria, in one of his early books. But it's really Thomas Morton, who was an orthopaedic surgeon from America, that really highlighted it, and that's why we call it a Morton's neuroma, even though it's not a true neuroma. It's just perineural fibrosis. In other words, fibrous thickening of the nerve. It's more common in females usually because of the footwear impingement, and it's most common in the third interspace between the third and fourth metatarsals. Next is the second and third. I've never seen it in the first interspace, and I've never seen it in the fourth and fifth interspace. People say they have. I've never seen it, and I've seen a lot of them. So it's just something to think about. The typical presentation is pain, numbness, horrible funny bone type pain in your foot, worse with direct pressure from footwear, and you get this sort of shooting pain into the toes and shooting pain back into the foot, sort of in this distribution. Now, the easiest way to describe it clinically is when you get this clicking in the metatarsal area. And the best way to do it is to do this technique where you're looking for a Mulder's click. It's called Mulder's when the person that first described it. And so the way I do it, patient is supine like that. You're gripping the foot with one hand, and then you're just pushing it up and down, dorsiflexing and plantarflexing the metatarsal, and you'll get this click. And that's called the Mulder's click, which is really pathognomonic for Morton's neuroma. It's more common in the third interspace because they say that anatomically the nerve comes together and it's slightly thicker there. So if it's going to be a problem, it tends to be there. But you can get more than one. You can get two, you can get four. So it just, so again, scanning is important. We're lucky enough here that we have ultrasound, so the patients can come in as a one-stop clinic almost and get a scan done by me. We can identify it and then we can activate treatment. So ultrasound at the top. Ultrasound is a bit cheaper, it's easier to do, it's operator dependent, so you can be there pushing the foot up and down, getting that Mulder's click and watching it pop in and out. But if you have, or you're not quite sure, you can do MRI. These are T1, T2 weighted scans, and you can see where it's arrowed there, and the white area, that's like a fat suppressed scan. And it just shows that where the neuroma is sitting, and they can be quite big. I mean, they can be up to 2 centimeters, which is quite big. And obviously that will depend on the treatment, how big it is. So what are the treatments? As I said, footwear is important. Get them out of tight-fitting shoes, that'll help. Makes a big difference. Sometimes you don't need to do anything else other than that. Insoles are good. Orthotics with the little pink bit on that insole is just a plantar metatarsal pad that just offloads and slightly spreads the toes out. So that's helpful in alleviating some of the symptoms, but it can't be too bulky, otherwise it pushes the foot up and actually makes it worse. There's no evidence to support if they're flat-footed, pronated or supinated, if that makes any difference. There's no evidence to support that. The right hand side, sometimes they can use shockwave. That's been used. That's actually on a heel because I couldn't find one for a neuroma. I've never done it. I can't see how that can really be helpful. Obviously, in the middle is the ultrasound is important, and ultrasound guided injections, so corticosteroid injections, can be helpful, and sometimes they're good diagnostically to find exactly where the lesion is. So if you're thinking about your differential diagnosis and you're not sure, there's a number of things going on. If you inject the nerve with just a bit of local anaesthetic and the pain goes away, you know you've got that as the problem. The actual injection there is ethanol, so it's an alcohol injection. I used to do this at one of the hospitals I worked at Broad Green. There's been some evidence to support it, but it's very, very painful. Very painful, so I never do that. The other option that was always considered was surgery. It was either surgery on top of the foot to cut the nerve out, or surgery on the bottom of the foot to cut the nerve out. We don't like doing it underneath. Does anybody know why?
Walking on it.
Yeah, and it causes scarring. So sometimes the scarring can cause more problems than the actual original.
Quite thick pad as well, I imagine.
Just that quick pad, and sometimes if your apposition and skin closure is very good, you don't notice it. And I did have a surgeon that I used to work with who was brilliant at doing that. And it's easier because it's more plantar than dorsal. If you go dorsally, which I have done, you've got to go through the foot itself and then take some of the layers out and then take the nerve out. 30% can get stump neuromas. So where you cut the nerve, you amputate the nerve, and what's left develops a stump neuroma. In about 30% they're saying now, and again, that's worse than the original problem. Oh, and this one here on the right hand side, it looks like cryosurgery, but it's actually radiofrequency ablation, so you can burn the nerve, so you can heat it up. So we're thinking about freezing the nerve, whereas some people radiofrequency ablation. The problem with, I'll discuss that again later. Okay, so this is where we come looking at, so what treatment do we have here that's innovative and different? It is cryosurgery. It's not utilised in many centres throughout the UK. There's only one or two other than ours. And the system here that we use is a seed-net system used in Boston Scientific, and this allows for a very small ice ball to be formed in order to ablate the neuroma. Again, under image guidance, the actual left-hand side is actually a CT scan. It's nice to illustrate the way the needle's going in. We don't use CT so much. It'll all be done under ultrasound, which is the bottom figure. But you can see that the ice ball is formed at the end of the needle. And there's some images that we actually did today. This is a patient that we operated on this afternoon. And the patients come in supine. It's a local anaesthetic, infiltrate dorsally in the foot, with a little bit of short-acting anaesthetic, lidocaine, 2% plain, as well as a long-acting bupivacaine, 0.5%, which is infiltrated into the area under ultrasound, and that numbs it. And I also put a little bit interdigitally, so it goes in the web space, along the course of where I'm going to put the needle. Then under ultrasound guidance, it's then injected, and then so the ice ball is developed inside the foot. The argon gas that we use takes it down to about 50, 40.
For Morton's neuroma?
Yeah, I know it's higher than that, but in the body, it's...
the temperature?
Yeah.
Oh, the needle goes down to minus 120,
Right.
and the temperature, probably not at 2 minutes, and the temperature in the skin is about minus 40, yeah?
Yeah, something like that. So that was the difference between the nitrous oxide, which I used to use, that didn't take it cold enough. So this does, it ablates the tissue. And you can see the toes are separated on the right-hand side, and that's because the ice ball is sitting in there now, once the needles come out. And it'll just stay there, and then it'll be dissipated over the next 24 hours. The patient walks in and patient walks out. I did some, when I was at Broad Green, a little bit of research into various aspects of whether the procedure was doable, which it is, and a little bit about post-operative recovery. And we found by doing MOX-FQ on a number of cases that the improvement was around 60 to 70%, which was comparable with surgery. And I read a paper when preparing for this that came out in the middle of last year from orthopaedic surgeons using the seed-net system, for enough, in France, and they had similar around 60 to 70% success rate. And that's just I'll just skip through that fairly quickly. So it's safe. There are obviously complications that can happen. Sometimes you can get residual numbness, sometimes you get swelling, and that's why when they have the procedure, I always give them an injection of steroid or corticosteroid just to reduce that swelling. Obviously, from a research point of view, you're putting in two different treatments, but essentially that's just to stop the swelling. And occasionally it needs to be done more than once. We've had cases of big neuromas, have rescanned them, they've reduced but not by enough, and therefore we've gone back in and done it again. There's some references to discuss as well. And so that's really a quick overview of Morton's neuroma, treatment with cryosurgery, which is very innovative, and I hope that's helpful.
Thank you. Any questions?
So the success rate's about 60 to 70%. Do you find that the patients that it's not successful in have got some common variables that might be diabetic or something like that?
Yeah, again, it's that mixed bag, comorbidities that are going along with it. It's the fact that they will change their footwear, and it may be that we need to look at the diagnosis again, or it's just the neuroma's too big. So what we found is they've had to go for a second procedure in order to reduce, because it's just too big to replace with that. Just to say that I do operate on, like we did today, bilaterally, but I don't do it in two neuromas in the 1 foot, only because of the risk of any ischemia to the metatarsal, which was one complication I had when I first started many years ago.
Do you find, you mentioned when surgery was you get scarring,
Yeah.
so do you have an issue with scarring when you use cryo?
Haven't had it. Again, some people have had, most patients that I see will get an improvement, but it's when we say 60%, that's complete resolution of symptoms and everything's gone. And it's comparable with surgery, but it doesn't have any stunt neuroma complications, and it doesn't have any, when I'm talking about surgery scarring, it's actually on the skin itself. So you get a nasty scarring and you develop callosities, and you've got that for life, then it's very difficult to manage it. Internal scarring, I've not come across that with cryosurgery.
Yeah, because I believe with surgery, one of the issues with surgery is it can create more scarring. It's almost
Absolutely.
then it, and you resolve the problem for a short while,
Yeah.
but then you actually get a bigger problem later down the road because it's bigger and more
I've
scarring.
not done an open formal operation on these for 2 years.
And the neuroma won't resolve. Once you've got it, or will it eventually regress? Or
They can regress again if you reduce it with footwear and stop that impingement. It can ease off, but it's usually always there. Really,
what's MOX-FQ? Just that.
it's Manchester or Oxford. It's just a validated questionnaire, so it's a bit like a Likert scaling, but it's just done over 100, and it means that you can validate it sort of 3 months post surgery and then 6 months and 12 months.
Compare.
But it's a validated questionnaire for foot and ankle surgery.
I've got a very important question. Did Queen Victoria have one?
Yes.
Did she?
That's when they thought it was. Yeah, she did have one.
Was she a prime candidate with her?
Yes.
Well, thanks very much, Jimmy. That's really clear, and
Okay.
it looks like a great procedure, doesn't it? I mean, the results are good, simple. Patients in that how quickly is a procedure?
20 minutes, half an hour.
Sometimes it takes longer to get the patient on the table than the actual procedure. The procedures, the actual freeze is 2 minutes, and then how long it takes to get the needle in. So it's 5 minutes.
They're booked in every 30 minutes by the time consent them.
And do you anaesthetise them? Do you numb it before?
Just local,
Just local.
Just local infiltration. Don't use it anymore. I did, started doing ankle blocks and that, but that's more painful. And I mean, we had the patient today, never had any pain whatsoever.
One of the advantages of cryo is ice is an analgesic. Ice is a painkiller.
Yeah.
So actually that helps.
Yeah.
With it, so a nice amount of local and steroid, and then the ice will thaw over a couple of hours. So sometimes they might get a little bit of discomfort, sort of 3 or 4 hours afterwards when the anaesthetic's worn off and the ice has gone, but generally immediately they have no pain and they probably don't know even that they've done it.
Yeah.
When we do kidneys, we freeze kidney tumours, which is the main job of the kit. Those patients are very hard to keep in hospital overnight because they literally do not know that they've had a procedure.
That's why I give them the bupivacaine, because it'll just last about 6 to 8 hours.
Yeah.
So it means that it gets them over that first bit.
Yeah, so well tolerated and not invasive.
Yeah.
Win-win.
I know, that's it.
Yeah. Thank you. Thanks very much.
Okay.